Clinical Cytogenetics 1, Common Autosomal Trisomies and Chromosome Deletions, Module 2, Lecture 1 of the Genetics series. The objectives of this lecture include to describe clinical characteristics associated with Down syndrome, understand clinical characteristics of Patau syndrome and Edwards syndrome, recognize the clinical characteristics of common terminal deletions, including 4p-, which is Wolff-Hirschhorn, and 5p-, or Creta-Shad. So autosomal aneuploidy syndromes include trisomy 21 or Down syndrome, trisomy 13 or Patau syndrome, trisomy 18 or Edwards syndrome, 4p deletion or Wolff-Hirschhorn, and 5p deletion or Creta-Shad. A syndrome is defined as a number of features put together. Sometimes it's genetic, sometimes it's not, but all of the word syndrome means is a number of features put together. Down syndrome was originally described in 1850 by Dr. Langdon Downs, and he saw children that looked more like each other than other children in their family. It was not till 1959 that we realized that the clinical diagnosis of Down syndrome was caused by having an additional copy of chromosome 21. We're still not certain why the additional chromosome causes the problem, but we know that children with an extra copy of that chromosome have similar physical characteristics. The types of chromosomal abnormalities seen in Down syndrome, the vast majority have an extra copy of chromosome 21 in all the cells in their body, or 47 XX or XY plus 21. 2 to 4% are mosaic. That means that the pregnancy started with the additional copy of that chromosome in all the cells, but in a small portion, or depending on how severe it is, of the cells, that extra copy is lost. If the less than 20% of the cells have the extra 21, it can result in a milder phenotype. In most cases, it doesn't significantly affect the phenotype. And then a translocation is one of these chromosomes attached to another, and this is known as a Robertsonian translocation. So this individual has 2 copies of 14 and 2 of 21, but this individual has a 14 to 21, and this 14 to 21 is attached to each other. So Robertsonian translocation is a word that we use when describing translocations between acrocentric chromosomes. We have the acrocentric chromosomes include 13, 14, 15, 21, and 22, and the short arms of these chromosomes have repetitive DNA. So in this case, we actually lose 2 what we call nuclear low organizing regions, or NORs, at the top of the 14 and the 21. But 8 copies of repetitive DNA, 10, that's not really the problem. The problem is when we're distributing our chromosomes during meiosis. If the normal 14 and 21 go together, then the baby will have, and they receive 114 and 121 from the other parent, that's fine. But if this 1421 migrates with the 21 and the other parent donates normal chromosomes, we end up with 2 copies of 14 and 1, 2, 3 of 21. The risk of having a baby with Down syndrome increases with increasing maternal age. And so the risk is relatively low under the age of 30. It starts rising between 30 and 35, and then after 40, it really takes a steep curve. This is the risk of Down syndrome. It's a type of amnio, and this is at birth. A significant portion of babies conceived with Down syndrome are lost during the pregnancy. A much higher risk of the chromosomes 13 and 18 are lost during the pregnancy. So Down syndrome is a relatively common disorder occurring in about 1 in 500 to 1 in 800 live births. 4,000 to 5,000 children in the U.S. are born every year with Down syndrome, and it affects 250,000 families. Anyone going into primary care will probably be caring for an individual with Down syndrome. The life expectancy now is about 50 to 60, but it continues to rise. Even though the risk of having a baby is higher as you get older, the vast majority of babies with Down syndrome are born to women under the age of 35. And that's because even today, the majority of babies are born to women under the age of 35. So as a woman gets older, the risk to have a baby with a chromosomal abnormality also increases. And this is actually just a chart. At the age of 25, the risk of having a baby with Down syndrome is about 1 in 250 of any chromosome problem, close to about 1 in 500. By the age of 30, we're now at like 1 in 385 of any chromosomal abnormality. At the age of 34, it's 1 in 244, and then at 35, it's 1 in 178. But by the time you get to 49, it's 1 in 7. So why is 35 the magic age that they start offering prenatal testing? Well, the initial studies on the risk of pregnancy loss in Down syndrome, amniocentesis, in the 70s was estimated to be 1 in 200. I might add that amnio was done at that time without ultrasound guidance. And so they said, why would you offer an invasive test to somebody when it's more likely they're going to lose the pregnancy than find a problem? So that's why they started offering it 35, and that's why that magic age is 35, and everybody thinks they have to have their kids by 35, which is a fallacy. Today, the risk of pregnancy loss due to amnio is less than probably 1 in 500. So if we use that same thought process, everyone will get an amnio. But since that time, we've come up with a number of non-invasive testing methods to determine, like through a blood test, if someone has amnio, which we will go into in more detail during the prenatal lectures. Ultrasound signs of Down syndrome include a thick nuchal translucency, so this is fluid in the back of the neck, congenital heart defects. As I stated earlier, there are non-invasive testing, and there's both ultrasound and blood testing that can be used to determine who's at higher risk. But it doesn't really matter if the chromosome is attached to another, in this case of a translocation, or you just have an extra copy, the phenotype is the same. So I couldn't look at a baby and say, oh, they have a translocation. Clinical phenotype includes this epicanthal fold, is an extra fold here in the eye, a wide space between the first and second toe, a single palmar crease. They usually have low muscle tone, and they do a lot of tongue thrusting. The thick nuchal fold is probably the remnants from the translucent extra fluid back there. About 50% have a heart defect, and they have low muscle tone. The Robertsonian translocation, again, it doesn't change the phenotype. It only changes the recurrence risk for a future child. So a woman under the age of 35, the risk of having another baby with Down syndrome is about 1%. A woman over the age of 35, it's whatever their age is, their age risk is that time. So if they're 42 with the next pregnancy or whatever that age risk is, that's actually higher than 1%. If there is a translocation, however, the recurrence risk could be 15%. This is actually the first person to ever have an amniocentesis. Both she and her mother were a carrier of a 1421 translocation, and as you can see, she has 3 siblings with Down syndrome. The exception to the 15% is if there's a 2121 translocation. In most cases, when a baby has a 2121 translocation, that was just an event that occurred during the formation of the egg and sperm. But if it is inherited to the parent from the parent actually has 45 chromosomes, but both copies of 21 are attached to each other, and the recurrence risk to have a baby with Down syndrome in that case would actually be 100%. But fortunately, that's very rare. Patau syndrome or trisomy 13 is fortunately much less common with Down syndrome because it's much more severe. Clinical characteristics include holoprosencephaly, where the brain does not divide into 2 halves, microcephaly, cleft lip and palate. Here we have the polydactyly, very severe congenital heart defects. Most babies die within the first few weeks of life. Less than 10% make it to a month, and less than 1% make it to a year. Here we have a karyotype, and there's 47 chromosomes, and there's 3 copies of chromosome 13. Edwards syndrome, or trisomy 18, is characterized by intrauterine growth retardation or small baby. Not only does the baby have that extra copy of the chromosome, so does the placenta. These are rocker bottom feet. This overlapping finger, this is a very specific finding of trisomy 18, and I've even seen pictures like this on step 1 board exams. Malformed ears, I've even seen children with no ears, and the majority of the babies, 90% die by age 1. So only 10% of these children make it to 1, and very few make it long term. And if they do, they have very, very significant cognitive deficits. And here we have a karyotype with an extra copy of chromosome 18. So partial chromosome loss, and this usually occurs during the formation of the egg or sperm when they're copying the chromosome. It doesn't copy all the way. So partial deletion of chromosome 5, clinical characteristics include microcephaly, growth deficiency, a high-pitched cat cry. That's how they got the name cri de chat, because it was originally described in France, and cri de chat in French is cry of the cat. Congenital heart defects, and low muscle tone. Most cases are sporadic, about 2%. It's caused because of an unbalanced chromosome translocation inherited from one of the parents. If it's inherited, the recurrence risk is higher. In most cases, recurrence risk is less than 1%. Clinical characteristics actually depend on how large of a piece that's missing. So if you just have a small piece up here at the end, the phenotype is milder than if you have a more significant portion of chromosome 5 missing. Wolff-Hirschhorn, this is characterized by cleft lip and palate, and it's caused by the deletion of the short arm of chromosome 4. So we have a cleft lip and palate, kind of downturned corners of the mouth, wide-spaced eyes. This is a very significant hypertelorism, low muscle tone, and severe cognitive delays. They used to call this the Greek helmet face because this almost looks like one of those Greek helmets that came down. And this is, again, caused the larger the piece deleted, the more significant the cognitive deficits. We'll talk about cleft lip and palate in the future, but one of the things I also always tell families is, or like residents, if you put a piece of paper over here and you say, does this baby look normal? If you're not looking at the cleft lip and palate, if your answer is yes, then it's probably isolated cleft lip and palate. But this baby also has a small head, has, low muscle tone, things like that. And these are most kids with cleft lip and palate have a little bit of hypertelorism, but this is incredibly significant. Again, the larger the deletion, the more severe the phenotype. So, a baby is born with multiple congenital anomalies, including cleft lip and palate. The most likely cause of this is polydactyly and heart murmur. So deletion 5p plus 21 plus 18 plus 13, and the correct answer is trisomy 13, because if 5p minus would be the high-pitched cat cry and the microcephaly, this would be a low muscle tone, thick nuchal fold, maybe a heart defect, simian crease, overlapping fingers, rocker bottom feet, and we didn't talk about Turner syndrome here, but that is the correct answer. And this concludes this module.